Mathew is a sociologist and demographer. He received his PhD from the University of Pennsylvania in 2009. Before coming to the UPF in 2011, he worked as a postdoctoral fellow in the Office of Population Research at Princeton University. I think that almost everybody here knows him, more or less. One dimension of his work focuses on the link between immigration and health in the Mexico and US context. So it's one of the reasons why we have invited him, because we study health inequalities and the social axis related to health inequalities. And one social axis is the migration status. So it's an interesting project to present here for our group. And well, Mathew is particularly interested in the link between process of social and economic incorporation of health. And he also works on applications of experimental design to study intolerance. He has published in public health, sociology, urban studies, history, and demography. He will make his presentation in English, but if you want to make the questions in Spanish or Catalan, it's welcome. Thank you.
Thank you. Okay, so here are the rules. I'm going to present. And at any point during the presentation, if you have a question, you should ask it. Okay? I assume there's going to be no moment at the end that will clearly transition into questions if we work that way. But of course, there'll be time at the end if you'd like to save your questions and increase the impact and quality of the questions throughout the presentation, that's fine. We communicated in English before this, so I assumed I should present it in English, and that's what I did. So you ready? Mm-hmm. All right. So this is a kind of a summary of a project that's finishing, but still has about another 6 or 8 months in it. And it came to, so far anyways, we've pulled 3 publications out of it. The first one was maybe 1.5 years ago. The last one came out recently, I don't remember when. And then the most current bit that I'll show at the end is the one that's currently under review. And it's a pretty big collaboration, so I don't want to leave anyone with the impression that I stand alone in this work. And you can see some common threads with it. Noreen, who is in some ways the big motivator behind the project, but also people like Graciela Teruel and Luis Rubalcaba, who are the principal investigators for the Mexican Family Life Survey, which is the underlying data for about 2/3 of it. And Pedley, who is on 1 or 2 of the papers, is for LA fans, for those who work on health at the kind of macro level. These are 2 in the US. Mexican context, these are the 2 big data sources with high quality, well, LA fans not quite as high quality in terms of health, but for other reasons. Information about immigrants with a sample size of substance and significant size that allows us to say a few things that we'll say. Okay? All right. So these were this was the idea behind the project. So these were the early meetings we had, in which we had all these intentions, and it really came from a sense of frustration. So those who follow the literature on immigrant health, you'll find, particularly, on the one hand, it's often dominated by the U.S.-Mexican context. So when people talk about immigrant health, they're really talking about one specific type, one specific dimension of it. And it really focuses on social transitions. Maybe it's because for the public health literature, the demographers, many of them trained in sociology, tend to emphasize social processes to a large extent. But I find that it kind of works somewhat only on the margins of public health and somewhat more comfortably within typical social stratification paradigms. So we were questioning, we wanted to consider the link between social migrant networks and health change. I'll talk a little bit about where that came from. But sociologists love social networks. It's like our thing. Social networks, so we feel really comfortable with that. Now we're interested in the transmission of information, interested in transmission of behaviors, the information of transmission of anything. I find that a sociologist, me included, can pretty much attribute anything to a social network if we want to, given enough time. The other part is something that may not be as familiar to this audience, but is included, it's like topics for panels in most of the major population studies conferences in the Americas is something about what they call the Hispanic paradox, occasionally the Latino paradox, occasionally the immigrant paradox. And this is basically the kind of preoccupation, mostly with US researchers, with the fact that immigrants are way more healthy than they should be. So there's a sense immigrants are just too healthy. They're not rich enough to be that healthy. They're not, I don't know. In some cases it gets into ethnic differences that should preclude them from being as healthy as they're observed to be. So that paradigm kind of sits there, and they call it the Hispanic paradox. Paradoxical Hispanics. Many of my colleagues are Hispanic, so they're always paradoxical. Okay, and the last one was intended to assess this social process, which is captured by a word that sociologists abuse and misuse frequently, and public health sometimes even worse, which is a process of acculturation, which is often used synonymously with processes of integration and social incorporation. Although there is nuance, I'm sure that social psychology and anthropology in particular could give us a much cleaner definition, but in the public health literature you often find that acculturation, integration, talking about social integration, are used almost interchangeably. So this is what we intended to do. So we were really excited. We thought we were going to, because we had high quality data. So we're like, let's do this. And this is what we didn't intend to do, which is mostly what we end up doing. So we didn't intend to introduce a whole lot of skepticism about social networks and health change. That was not the idea. And we wanted to privilege social networks. So that was troubling. We didn't really want to find only at the best weak linkages with acculturation. This was a paradigm that had almost been, I'd say five years ago, at least in the demography literature, something that was accepted outright, was that acculturation in US processes. It was the idea, and it's very appealing to say that just basically in a general sense, America and being American is bad for your health. So this was the idea. It was like America is a giant cigarette, and you increasingly become addicted to it as years go by, and that has health consequences. Okay, so we'll talk about that. But that it's not that there isn't interesting stories to tell, but this kind of social acculturation process was one that I would hope that I can inject a little bit of skepticism into the audience. And the third unintended consequence, or a consequence that was not intended, was to find immigration as a negative role in health relative to never migrants. Okay, if anyone remembers, quickly, the quick introduction, the Hispanic paradox is supposed to work this way. Immigrants arrive to the US and they're just like super people, and then their health atrophies that the longer, normally acculturation is synonymous with duration or generations. So normally people don't even measure any sort of substantive aspect of acculturation, it's just time since you've been there. But as time goes by and you're exposed to the disease that is the United States, your health declines as time goes by, right? But when you start, you're really good off. So we found some stuff that was a bit troubling when we actually had pretty good prospective panel data to look at immigrant health immediately after arrival, and kind of changes in that. Mind you, it's self-reported health, so take it with a grain of salt, as we say. Okay, so I'm going to start with the first one. This was phase one of the project. We're going to go through three of them. This work's been published, and so, but I will spend some time talking about it if you want. So this was migrant sending households, and so this was what I liked to do. I like to work with, actually one of the reasons that I got involved in this project is because I mostly worked with kids in Mexico and sent migrant sending households. So we want to know about obesity. Everyone's like, well, why obesity? One thing is because obesity in the United States is really popular. We even have our own class of athlete that is both obese and extremely successful. So we have an entire kind of cultural paradigm of athleticism that doesn't preclude obesity. I took the BMI, professional baseball players in the US, and they're definitely high on the scale, and it's not muscle. Okay. What we know, Mexico is undergoing unprecedented increase in prevalence of overweight and obesity among children. This is true. The difference between the United States and Mexico has increased, particularly on gender differences and the prevalence of obesity and overweight. They're on par, and actually Mexican women are slightly more likely, or the prevalence of obesity in Mexican women is higher than you find in the United States. So these two countries, if it's a race, they're tied, and maybe Mexico's winning the race to be the most obese country in North America. We'll see. Another thing that people noticed was that in the U.S., obesity in general and obesity among Mexican immigrants to the U.S. in particular was even higher. Now, I don't think it goes without saying that obesity has a clear and consistent relationship with declines in health and a huge cost, particularly in contexts where the healthcare system is in charge of providing services. Obesity is not a joke. So a lot of people want to put it into a category of kind of choice style health problems. So like, you're fat. But the health consequences and the cost of an obese population are remarkable, and particularly among children, the probability of going back. So if you cross the line to overweight and obesity as a young person, it's very difficult to recover as the life course goes on. So this is not something, it's very well measured and internationally comparable, which is why people tend to study obesity, but the health consequences can be quite substantive as the years go by. Okay. Any questions? It's kind of nice to have an American talk about fat Americans. You know. Okay, the other thing is, so we got an obesogenic context on both sides, but at that time, we're looking 2002 to 2005, Mexico was lagging behind. The United States, there had been some nice work done, particularly by Christakis and Fowler, which has subsequently been criticized somewhat, but this was stuff that was published in the New England Journal of Medicine that looked at social networks and obesity and basically proposed a causal link in that you can socially transmit behavior, and it's not a selection process into these networks, in which you kind of create a kind of feedback loop in which actually having friends who are in a certain sort of health disposition affects your health disposition. Christakis in particular, Fowler less so, Christakis is obsessed with social networks and genetics. I mean, if you read his papers, it's always social networks or genetics, and now genetics in social networks, okay? So, you know, social networks were something that he found to be very useful to explain this. I accepted it as it was. Subsequently, it's been criticized a bit by Cohen Cole in maybe 2009, 2010. And then there's this qualitative research on social remittances. And this is an interesting thing. Sociologists enjoy qualitative research, or actually quantitative sociologists like to say that they read qualitative research. Well, I did read qualitative research, and there's an interesting process of social remittances. Remittances normally typically are monetary, but there's also an aspect of the transmission of values, behaviors, and norms that transfer through those same networks was the idea. Okay, so we kind of put these things together, and we wanted to know a few things. We wanted to know, has Mexico-U.S. migration led to an increase in obesity among migrant-sending households? This was the idea that there was some aspect of the very rapid change in the prevalence of obesity and overweight in Mexico, particularly in households in which there was either A, closer to the border, or B, were in households in which they had a stronger social network with a more obesogenic context, which would be just about any context you want in the US. I mean, there's some outliers. Atlanta, Chicago, and Philly are even bigger than normal. Houston, too. But in general, it's pretty much overall, at that time, would have been relatively higher prevalence of obesity. Can we observe these changes in behavior? I'm more of a mechanistic modeler when it comes to population level health. So I wanted to know, I wasn't really interested in purely whether or not you're in a migrant household or not, and what's your BMI. I wanted to know whether there was any sort of detectable behavioral or dietary change that would help us understand this process, okay? And then what was the role of remittances and or economic change at the household level? So there's two aspects of being in a migrant network in the US that are somewhat relevant. One is that you have all this information and all these interrelations, and at that time, although increasingly less so, somewhat in some places a very cyclical, temporal, continuous flow of updated information. And on the other hand, you have a lot of money. Remittance networks are substantive, and in percentage terms, in terms of the national purse of Mexico, can be over half of all incoming cash flow to Mexico comes in the form of remittances. Okay? So, all right. So we did it with a data set, which is the Mexican Family Life Survey. We had 2 waves. The third wave will be coming out soon. For those who are interested in working in Mexico, I strongly suggest, or we're interested in working on migration more broadly, it's very high quality data, prospective, longitudinal, with baseline objective health measures. It's a very, very rich data source for this. The third wave will actually have, for the first time ever that I can think of, follow-up objective health measures, meaning that you have a health professional doing everything from blood spots to assessments of height and weight with immigrants in the United States, done with a Mexican team. So this work is fielded out of La Universitat Iberoamericana, which is just outside of Mexico City, and has a very high level of confidence with the people who are in the panel. Something that is very difficult for US researchers to do for the high level of suspicion, and there's really no cost to opting out of being in a panel as subsequent phase go through. Okay? We have a lot of households, we've got a lot of communities, although it's not fully representative at state level. I think there's some states that have very poor coverage from it. Linked to the 2000 census, which was updated with CONAPO, which is kind of the population gurus in Mexico who provide summary metrics of things like migration, incidence rates, migration marginalization, these kind of the typical income and income socioeconomic inequality measures that you find at a geographic level that you can link directly to this. So it's a pretty powerful data set as they go. It's got really good follow-up. I was told that was rounded down to like 92, 91% of the survey in 2002 were relocated in 2005, but over 90% of immigrants, those that migrated between the two waves to the United States, were found again, which is very, very high. And it's cool. The team that does it is very good at what they do. And so I watch them keep up with these people. You track them every month as the years go by, and then you do a resurvey in 2005 with the full field survey, which is extensive. The immigrants in the US were only interviewed with a telephone survey in 2005, and will be followed up with the field team in 2008, 2009. Will already happen. Okay. We modeled this in a pretty straightforward way, I think. Should be some Z's here. Regardless. Basically what we did is we looked at the probability of transitioning to overweight or obese. We used the the Task Force on Obesity that creates a metric, a sliding metric of overweight and obesity for young ages, because the typical cut points are done on adults, and so for this age, that's what we did. So we had age-specific cut points for overweight and obese. And we looked at transitions between the two, okay? Mind you, we're not using the migrants in the US for this one. I'll show you something later when we do that. We're just looking at within Mexico and migrant-sending households. So households in which there's a migrant household member, and we talk a little bit about how those networks work, whether you see some sort of transition in terms of behavior as well. Kind of goes like this. Not much to explain here, but you can see that there's a fair amount of transitioning among kids. Mind you that this is not all obese. This is overweight and obese, okay? Yeah. I haven't looked at myself recently. I may walk the line. We'll see. And this is the transition, so about a 21% transition, okay, between the two, which is pretty typical for that age range. Okay. Networks, we looked at this way. This is from recontact information. We can identify all members of up to 5 members of any household member in the household. So, you know, it was a full household survey, so everyone was asked a question. And we could identify whether they had close. We identified as a parent, sibling, or child who was living in the United States. At the time, it was considered to be a potential contact there, meaning someone who had a long-term residence of a year or intended to be a year in the United States. We had extended, which were people we consider we were using. This is very normative, by the way, as networks go. This is very family normative. Okay, so everyone here is kind of shaking their head. But you go to some audiences and the paradigm doesn't totally make sense. But we did the extended, which we consider to be 1 degree of separation on the typical nuclear family paradigm, which is grandparent, grandchild, uncle, aunt, niece, nephew. Then we have other. There's actually not that many others. So where everyone gets all upset with the other, there's not that many others. Okay? Others there, but it's just people who had kind of a non-defined relationship. But most people, for the list of top 5, they had 5 on the list, all the way down to the 5th one was a relationship that you could identify quite cleanly. Okay? So this is what we got. And I don't know what your preferences are, but I tend to show tons and tons of regression coefficients when I go through this. But you can see across the side kind of what the models plus the controls are, and I can talk a little bit about them if you want to. But behavioral measures are measures of the amount of time that you spend doing a number of tasks. So we have domestic, we have things that are outside the household, everything from cutting wood to tending to animals, including whether or not you fed the chickens. I mean, it's a very, very long battery of time use metrics that go through. One of the assumptions is that many of those tasks would no longer be necessary, as you could buy your way out of them, assuming you got higher amounts of financial compensation in the form of remittances. We had tons of behavioral, diet. These were all kinds of different measures of what you ate, how often you ate it, the type of food you ate. It was a pretty extensive battery of Now, there's a lot of complaints in the literature about the ability to even measure, particularly retrospective dietary. These were 24, 48-hour recall measures of dietary, and then the simple question, which everyone says yes, which is, was that day normal? You know, so, but there's really not much variation in that type of variable, so it's kind of a useless question, but I suppose you should keep asking it. We have economic well-being, social support, and community-level measures. Community-level measures were typically things about marginalization indices, and also to kind of play nice with the Mexican migration project. We had community levels of migration intensity, because that is a very high predictor of a variety of things, including infrastructure that comes from community-level influx of remittance income. Okay? Okay, right, so now that I said all that, what are we looking at? So basically we see these are the predicted probability of transitioning an overweight and obese, and you see a probability that's significantly different than 0 for those that have an extended network, that means a diverse network. I mean, some people have argued with these results that this looks kind of like the Grenovetter style, the strength of weak ties argument, in that people who have a more diverse network are the ones who get a more variety of information and can more easily select the information that they want to use. The same goes for this. We found this to be significant, but not nearly as strong as we would think. Higher probability of people who have an extended network in the US of transitioning into overweight or obesity. But we also, and I want to point out, if you look between model 2, model 3, model 4, those coefficients are extremely stable. Meaning that we account for a variety of behavioral, dietary, supposedly more proximate determinants of these transition that should affect or explain some of the transition probabilities, and we didn't really get very far. Okay, so kind of just keep that in mind as we go through this. Is that we had one better than just having, you know, whether or not you have a migrant network. We found that relationship. Okay, but it's pretty clear to me, anyways, that a lot of these ideas that the migrant network leads to a kind of diffusion of behavioral norms, the kind of video games and soda approach towards talking about obesity, it didn't seem, we couldn't really find much evidence for that as explaining what those networks did. And we had piss-poor measures of remittances, okay? Meaning that there's a lot of skepticism about whether or not what we're seeing here is an aspect of social stratification, and the kind of reversing gradients to help overall Mexico, which you're seeing, and or it's more of a kind of migrant social story. The sociologists would want to interpret this as kind of confirmation, and I tend to interpret this as weak confirmation to an extent, conditional on the fact that people were very honest about, particularly the economic well-being measures, how limited they were. Okay? But one would expect between model 2, model 3, model 4 to find something that we didn't find. Okay? Okay, so living in a household with migrant network, I've already said that. Extensive diet and exercise measures did not account for it. Community context did not account for it. And limited SAS controls did not account for it. Okay? So this means that we had proximate determinants that would supposedly be the markers of what these networks are supposed to provide in terms of normative social behavior that I suppose would translate into the kind of behaviors that you would explain to an extent these transitions. We didn't find it. The community context, we put that up there, like I said, mostly because we were trying to play nice with the Mexican Migration Project team. When you go to these conferences and present them, there's always half the room is for the Mexican Migration Project and half the room is for MXFLS, or MV, which is the Mexican Family Life Survey, and we tend not to get along that well. So we try to do some bridge building. But the community context we didn't see would have that much of an effect for this type of process. For other things, sure, particularly the probability of migrating. And the limited SAS controls are really troubling. And we'll talk a bit about remittances because there might be hope for remittances, but the remittance income or knowing what remittance income is being dedicated to, I think will help us get a long way with this story. Okay, pinpointing remittance income. We had lots of household transfer information, but we did not have very good information about its specific source. In other words, what extent was inter-vivo household transfers attributable to direct remittance income from international sources. Okay, other questions? So phase 1's over. Phase 2, we decided to cross the border and go north, and we went to LA. I've only been to LA once, which was kind of funny because I did a lot of modeling for this. But we had good people from LA who were there. I guess it's an East Coast thing. I only go to LA if I have to. Migrants in the US. Okay, what we do. Okay, we knew a couple of things. We knew the length of residence in higher generations are due positively. So we looked at the kind of secondary effects of migration to migrant households in Mexico. So we wanted to see in the US some of this acculturation stuff. So we were looking at, in theory, kind of a secondary process of acculturation. We've got normative change among migrants in the US, and we assumed that we would just accept that that happens. And then look whether that normative change was transferred back into sending households and whether you could see any sort of secondary aspects of that. Didn't work out so well, although some people thought it worked out really well. I didn't think it worked out that great. So then we went and we looked at migrants in the US, and we wanted to know a few things. We wanted to know the length of residence in higher generations are positively associated with decline in health among immigrants. This we know. There's a lot of literature that consistently shows that immigrants have this kind of paradoxically positive health association in the first generation or for shorter durations, and as time goes by, their health declines. Acculturation is all over it. If you look at this literature, and if you look at how the literature has been funded, acculturation is the kind of normative structure that defines the paradigm of health change among immigrants, and that they're incorporating into a society. Acculturation is often used synonymously, like I said, but without parsing the meaning of the two. And so as a result, there's a strong emphasis on social change. That's the most common, I would say, explanation offered across time by duration and generation, meaning that people take on, in terms of health, people take on health behaviors and normative attitudes, and if we're talking about obesity, towards food and exercise that translate into more negative health as time goes by and across generations. Okay, that's kind of the acculturation argument. So when they talk about acculturation, they're talking about a very narrow range of values. They're not talking about paradigms like how I feel about my identity at all. They're talking about measurable ways in which diet, exercise start to look more like those same behaviors in populations that are relatively less healthy across time. That's what they're talking about. People acting like populations that are less healthy. Okay. So acculturation is the most common explanation. It is, although there's some criticism of it, it's generally always put there. You always mention it. Obesity and duration of residence in the US are consistently linked in the literature. That's very true. Less true with generation. Intergenerational stuff is less clear than the durational model. Okay.
Can I ask you a question?
Yeah.
So those studies that look at health and acculturation, even if they, as you said, define acculturation in terms of generational status or how long you've been in the country, rather than measuring, as you said, beliefs and norms and sort of beliefs about health and.
Even worse, they don't even measure behaviors.
Okay, right. But I'm curious because health is such a broad construct, right? So you have, risky sex, smoking, getting mammograms, and intuitively I would think that some beliefs might predict negative health behaviors and some other beliefs might predict positive health behaviors. So, for instance, Mexican women are less likely, if they endorse traditional Mexican values, to smoke, which is a risk protection factor, but they might just. So it depends if you're looking at norms. This is the ethnic culture, or norms the American culture. So meaning that those are independent forces, not into health. So some ethnic, some norms from Mexico might protect them against some healthy risky behaviors. At the same time, they're also learning American values, and those put them at risk. So my question is it's so complex. How can you say that?
Well, I don't know. You would be, I think you would be scandalized by the way that a lot of these concepts are operationalized. But without going too far into it, this idea comes from basically a 1950s notion of assimilation. And most of the health literature is still kind of stuck in the straight line assimilation models. Then people thought they would go for a kind of a model in which you can kind of carry, it's still a straight line, but you don't necessarily have to go all the way one way or the other. Then they fragmented it. You get the segmented assimilation models, which kind of came out in the early 90s, mostly in the educational literature. And these, not to criticize my colleagues in demography, but we tend to be the kind of prostitutes of theory. So, if there's some good theories out there, we just kind of pick them up and, we'll take whatever theory we can take when it comes to these, because when it comes to acculturation models, because the nuance for us is mostly used to express why we would have a given expectation. And the average assumption is that given what we see in terms of a variety of objective health measures among immigrants after they arrive, that most, if there are a cultural link, let's say, or if you, I mean, they don't, you almost never see even the word culture appear. A few times with aspects of child and infant mortality and stuff like that, see that I remember. But this stuff is normally, the assumption is that the elements that are related to a health characteristic of interest, depending on what the outcome is, those elements would be protective if they're not American, and relatively would make the population more vulnerable the more that they are American, in that sense. Okay? The idea being that on average, the US population, these are macro level, on average the US population is less healthy than the population of origin. Okay? So they look at, they're not interested actually in measuring values. They're interested in measuring, the proximate determinants in this, in the health literature, would be behaviors.
Right, because American acculturated kids are more likely to use condoms.
So that's what they would want to measure. They would want to say, hey, how often do the American population use condoms? How much does a population that self-identifies as a variety of different measures? We'll talk about acculturation and generational measures. How often do they use? I don't know anything about condom usage between the two. But they would measure those differences behaviorally. Okay, the why, the mechanism behind, and the mechanism by which people decide that another paradigm, another way of doing it is preferable. I don't think this speaks to that at all, even on a cursory level. Okay. Okay. So we measured linguistic and social measures of acculturation. So we had generational measures, first, second, third plus generation of migrants. We went social and linguistic measures of acculturation. I'll show a brief blip about that. What's the link between generation, duration, acculturation, diet, and exercise? That's what we wanted to know. Okay, so we wanted, before we started talking about a health outcome like obesity in this case, we wanted to see whether there's actual measurable variation by levels of acculturation other than just this typical duration generation measure, but also kind of a more systematic measure of acculturation. Acculturation in this case, from the sociologist's perspective, is basically interrelationships and usage of language, depending on whether you mostly, sometimes, or always use the language of the country of origin relative to another. These models would fall apart in Catalonia completely. It would be very difficult. You'd have like some sort of like XYZ axis. But the point is that in the US it's not always that bad, or as bad as it sounds. Okay? Longer residence immigrants, the second or third generation, at a greater risk of obesity, and if so, do more proximate measures of social linguistic acculturation explain this greater risk. Okay, so we wanted to do two things. We wanted to measure whether acculturation has a relationship with behavior and diet. We wanted to measure whether the same old tired measures work. Our measures of generation, our measures of duration, whether they work, and we wanted to see if we could explain these kind of very, very distant measures of change using more proximate measures of acculturation. Okay, whether we could do that. Okay. This is all in LA, mind you. Okay? So there we go. You have to put it down there. That's where LA is. We use LA Fans, which is a very cool study collected by University of California, Los Angeles, and also RAND, and is publicly available. I strongly suggest people play with it. It's a lot of fun to play with. Okay? They have all kinds of neat stuff in there. If you like LA. They don't have the amount of people aspiring to be an actor. That's the measure I wanted. Okay. Predicted acculturation score by duration generation. These, just a basic kind of a predictive model. These measures were continuous, so I'm assuming that I predicted these from an OLS, but I'm not sure. I don't recall. It's been a little while. Anyways, as you go by, you can see they work roughly. Okay, so as you go across generation, this 15-year cut point is mostly dictated by sample size, but it's pretty common in the literature. People use this 15-year cut point. I'm convinced that although I've seen all kinds of theoretical gymnastics to justify that 15 years, I'm convinced it's mostly due to sample size. That's why we get to 15 years. So I'm not going to justify it on any stronger terms than that. And then we got after 15 years, the second generation and third plus. I typically don't like to define the third plus generation. I think it gets a bit weird at that point, whether we're still talking about immigrants at all. But basically you can see the acculturation measure go up, and so groups generally more socially and linguistically acculturated across generation. And also by duration, but although you can see the duration difference is quite small, okay, if at all, and it's not significant, okay? All right. So, greater exposure to the U.S. is associated with less fruit consumption and more soda and fast food. Okay, we were finding these. So the kind of soda video games, McDonald's effect, we were finding some relationship with that, which is good or bad. Greater social linguistic acculturation predicts fewer servings of fruit and vegetables and more fast food for some models. Greater income predicts more servings of fruit and vegetables and fewer servings of soda. Okay, so this is the typical reverse social gradient. So people tend to, when they have lower incomes, tend to substitute healthy food for less healthy sources. This is something that you're finding as probably as a strong explanatory factor in Spain and Catalonia, which is seeing a very, very quick rise in overweight and obesity among children, and doesn't seem to really concern that many people. But you wanted to look there; it wouldn't be a bad place to start. Although I want to remind you, in the background, there's structures. Okay, so behavioral change is normally done within constraints. Okay, so what we did, this is obesity acculturation versus exposure. I'm not showing any of the other models. And so across, you see these just kind of control for different things. And I just focused on this one because this is the most analogous to what you see typically in the literature. And then you see we've got basically 3 generations, and you can see by the difference between first generation Mexican and third plus generation Mexicans it is not significant, but you see a rapid, relatively small population. And as you go across the control for a few other things, you can see that you basically get the gradient you would expect. Okay? So that you can see that obesity, or the probability of being obese, and this is obesity, meaning that this is people who have a pretty high BMI. Groups are significant of the odds of being obese for, let's say, second generation or third plus generation Mexican relative to the first generation or more recently arrived first generation more specifically are significantly higher. And we control for linguistic acculturation, we can control for social acculturation, and we can control for linguistic and social acculturation in these models, and we don't explain it. Okay? So we found that really, and this is a strong push by my co-author, and heavily, that you need to stop emphasizing obsessively this social change paradigms, and you need to start looking at economic constraints. So she's very, very much focused on how the household context and the economic insertion into the American society is something that creates trajectories that if you compare these groups in obesity rates to other marginalized groups in LA, you would find a much closer association than you would find. In other words, there's more similarity among Mexican longer duration or higher generation Mexican immigrants and other marginalized groups in LA than among Mexican immigrants between themselves by generation or duration. Okay? Okay. Phase 2, I think I'm running out of time, so I'm going to cut to the chase. I'm going to blast through this last one at least. Okay? So phase 3 was the last one. This is the one that's under process. And this one's pretty interesting in terms of design, because this is a one in which we said, okay, literally the meetings were like, okay, let's go to Mexico, let's do this project. And we're like, all right, that didn't work out so great. Let's go to LA, let's do this because we want to have something on the United States. That really wasn't what we were thinking. So we're like, all right, let's just do it all at once. Okay? So we're going to start in Mexico, and then we actually don't go to LA, although some of our follow-up is in LA, but we go to anywhere, we don't know. Okay? So we started with a prospective panel, and we started looking at immigrants before they migrate, and then we looked at a whole battery of health measures before they leave, and then we looked at self-reported health after they left, because we didn't have objective measures. Okay? So we decided to kind of put them together into this. This is what we knew or thought we knew, that Mexican migrants are positively selected for good health and healthy behaviors. This is a typical idea that helps explain this paradoxical thing you find among immigrants, is that migration is really hard, and then when they get to the US, they're relatively healthy or more fit, because they went through this relatively arduous thing. We'll inject some skepticism into that. But I like the idea of like somebody sitting in a laboratory somewhere in the United States, imagining like really strong migrants coming into the end and showing their healthy behaviors afterwards. I think it was a bit naive about how difficult and how kind of there could be some detrimental aspects of the migration process as well, particularly among the US groups. Okay? Living in the US leads to deterioration in both health and healthy behaviors of migrants, and the evidence for both the above assertion is mixed. So this last bit is very true. If you go through and do a systematic review of the literature, we don't know as much as we think we know about some of how these processes work. But I tend to follow a leader until I find another leader, so we were okay with that one for now, and these are the kind of what we wanted to test. Okay? So we basically start with a really simple question. This one kind of reduces down to one. It says, how does immigrant health change after migration? And we were open to it improving or declining. Okay? So you think about it, the typical paradigm is among people after they migrate to other migrants, so those same migrants across time, right? Or we're looking at migrant children in households, migrant sending households compared to children who are non-migrant sending households. But in this time we're interested about migrant health among the same people before and after. they migrate, right? And then we also had a control group of people who never migrated. So we had never migrated. So these are people who were in households in Mexico who did a whole bunch of things with their lives, minus migrate to the United States. Okay? So this was the kind of comparisons that we wanted to look at. I think it's pretty useful. It's pretty intuitive in that way. So MXFLS1 and MXFLS2 again, or the Mexican acronym is NB, and the follow-up phone interviews with migrants in MXFLS2. Follow-up for anyone who's ever done tracking in large survey collection of migrants is really, really expensive and really hard. I think Pao can attest to the fact that finding migrants in the context of destination is difficult and sometimes not possible. Okay, so they knew they didn't have money, or we knew we didn't have money to follow up all of them in person. So they did very, very consistent tracking across time, consistently calling and following up until they got it. And then they did a phone interview in 2005 with a battery of so the baseline we had a battery of objective measures of health, but we'll see we really only have 2 health questions in follow-up. The 2 questions you can ask with an indirect survey, which are self-reported health and then perception of change in health. Okay? MXFLS3, for those who are graduate students, which seems to be generally most of my audience, that will be really exciting time for those who want to study health, because MXFLS3 has objective measures among migrants from a prospective panel, which is almost unique. I don't know of any really other research design that has that to offer. Okay, so we ran a bunch of models. And these are the relative risk ratios, so they're analogous to odds ratios, but with a 3-part nominal outcome. And the outcome here is self-rated health status. So basically we control for baseline health, self-reported health, we control for a battery of objective measures of health, and then we look at self-reported health at wave 2, both among people who are in Mexico and those that migrate to the US. Okay, we have never, ever, and current, which is kind of a way to say these are people who have never migrated to the US, people who have migrated and returned to Mexico. And all the MMP studies tend to compare return migrants to never migrants. And current migrants, so people who are migrants and basically were interviewed by telephone in wave 2. We have all their baseline measures because they were all in Mexico in the first wave. You had to be in Mexico to be in the sample. Okay? So basically what you get is that current migrants, in terms of this is worse relative to the same, have increased odds, about 73% higher odds in model 1 of reporting worse, or self-reported health being worse than the health being the same. Okay, and this is a question that self-reported, those who aren't used to using this measure, self-reported health is, when it's asked well, as best it can be, is asked in this way. They ask you, how is your health relative to someone of the same age and sex? Okay, so typically they try to force you to come up with a reference group that's useful. Okay, I feel young, so I compare myself to an 18-year-old. It's subjective. Ultimately, it's subjective. Okay, and this is the one that Luis, who's another co-author here, was really trying to get at. He was curious to say, well, why don't we just allow it to be flexible in the sense that we could imagine that people actually report better health as well? You could basically get moving off the center point, why not? And we found some, it was significant, but it's for this one and the other one it's pretty marginal. So once we control, you can kind of follow the models if you want to, but for the first one we just have the typical age sex controls. The second one we throw in a bunch of measures of objective health. These are obesity measured in BMI. This is directly measured, this is not self-reported height and weight. This is directly measured height and weight. It's a pretty accurate measure of BMI. We've got anemia, hypertension, hospitalization in the previous year. We've got measures of marginalization, of migration intensity, and then your typical socioeconomic stuff, which is log income and then education. And you can see across models it really doesn't do much. Okay? So we're getting that negative health effect, right? Negative. Yeah, this is a really short follow-up. So these people have been in the US for less than a year. Okay? This is the same thing, but this is with health status relative to previous year or prior to migration for those that migrated. They ask the question directly, and you get the same thing. We did this as second. You can see that the no, we imputed. That's right. At the end, we imputed. We had some missing data for these. Okay, these are all done with multiple imputation for baseline health, because if you were measured by proxy in the baseline, many of those health measures are not collected. Okay, so we just see your typical 5-sample multiple imputation for the about 9 or 10% of the sample, which we didn't have information for baseline objective measures of health. Okay, you can see the same pattern. So I couldn't get this one to pop out. I wasn't really trying to make it pop out, but with the same general controls, I couldn't get this self-reported better health part to come through there, but the negative one is roughly the same. Okay? Meaning that. Okay, these are I'm not going to do this. These are the same things, but these are just predicted probabilities that are derived from the same model. So you get the sense. But you can get a sense that the magnitude's not that high. Well, whatever. Basically, it's confirmational if we were to walk through those predicted. So for the phase 3 conclusions, we kind of decline in health is rapid in contrast to previous work that considers health change to be part of a long-term process of incorporation. We found that in terms of self-reported health, overall health, the process from what we had was relatively quick. And this idea that you're having some sort of normative shift, kind of paradigm-changing process, is something that this doesn't find is required to explain differences in health. Okay? And also a number of proximate mechanisms require exploration. And this was a big push by our Mexican colleagues to be like, stop talking about migration as being something where people come out better than when they started. Okay? So increasingly rigid borders, social pressure on those who lack documentation, costs of finding and maintaining work, and access to healthcare. And access to healthcare is something that's very consistently, and including in Spain, is increasingly under pressure for people without documentation who are excluded more and more from preventative health, which one would imagine could be related. We didn't have measures of those proximate. In wave 3, you will have measures, particularly of access to healthcare among the migrant sample. Okay? So it'd be a good way to go with that. Okay? Other questions at this point? Okay, so overall conclusions, these are kind of project-wide conclusions. We have the socio-behavioral factors are of limited explanatory power in terms of long-term trends in Mexican BMI change. Okay? Doesn't mean that they're useless. It just means that we're not doing a good job of predicting how these things work. And the next one is acculturation is weak. Limited explanation of observed change in BMI for migrants in the US. Okay? This is acculturation in the public health sense, a very kind of crude notion of acculturation, but nonetheless something that translates across studies for those that do it. Most of this work came out in social science and medicine, so that's pretty much the audience that we were going for with this, was people who do sociology-derived, demography-derived public health. Okay? And the last one is health change can happen quickly, which suggests that mechanisms closely related to migration and linked to socioeconomic vulnerability are some of the likely candidates. Okay? I think that's it, except for normally you have to, these are all the people that gave us money, so you have to thank them. It used to be called the National Institute of Child Health Development, but now it's the Eunice Kennedy Shriver National Institute of Child Health and Development. I don't even know if they use an acronym. That would be the EKSNICHHD, if they did, which is an absurdly long title. And the National Institute of Aging, and NIH supported some of the funding for particularly LA Fans and the Ford Foundation, who did the first wave of MXFLS. Okay? Thank you.